Hello everybody, welcome back. This presentation is going to be a second part of head, neck and trunk, or in other words, axial skeletal system. Alright, so this is part 2. It's on the second PowerPoint, but the title is the same. Okay, and clearly says part 2, movement and posture. So I'm going to go to the next slide, and here you can see my very handy work about self-destroying skeletal. So let's go to the next slide. So motions of the head, neck and trunk. So what can we do, right? Flexion and extension, lateral flexion and rotation, and we already mentioned that. I already showed you that, but just a quick reminder. That would be flexion, extension, lateral flexions to left or to right, and of course rotation. Now what is this? One side or the other? Well, you said it correctly. Is circumduction, which is not an extra movement because it's just a combination of flexion, extension, lateral flexions. Okay, rotation would look like this. This is the true rotation. Okay, let's go to the next slide. So movement of the head and neck again here. So this is a capital. Let's take a look first at the top of the drawings of the picture. Capital flexion. Right below it you can see cervical flexion, and right below it it's combined flexion. And on the right hand side you can see capital extension, cervical extension, and then combination. So we learned that already in the previous video, that skull can move independently on C1, and that would be considered as cervical, either flexion or extension. And we can do this together. Just do it like this, like you're tucking your chin in. That's gonna be flexion, that's gonna be extension. So try to utilize only your skull as opposed to your neck. So that's gonna be, of course, the capital flexion and extension. So what's cervical flexion and extension, and how is different? Try to keep your head, your skull in one position, in one place. And now, kind of look like a turtle movement, right? Flexion and extension. You are very stiff because you kind of immobilize the cervical, capital, but you move only cervical portion. But in real life, we don't really use those movements separately because they're not as practical as combination of both. So when you are leaning down or looking down, let's say you look towards your shoes, you actually utilize both capital and cervical flexion. And similarly, if you want to look on something on the ceiling, you are going to utilize both into extension. So in reality, people who suffer from neck arthritis, they feel the difference, and sometimes one is easier than the other, or one is impossible. Especially the cervical flexions or extensions are very hard for people with severe arthritis, for example. But normally we would utilize both of them at the same time. Okay, let's go to the next slide. Here we got some muscles, all right? So capital extensors, a lot of them. I will not expect you to know all of those muscles. You don't have to memorize them. Those slides are for you just to appreciate how many muscles are involved in seemingly a simple movement, but we can appreciate now that it's really not. Nothing is simple, really, what we do and how we do it and how we are accomplishing our really sophisticated movements. Okay, let's go to the next slide. Another set of muscles. Again, you don't have to memorize them, but just so you know, you have that mental picture. Cervical extensors. Then you got capital flexors. The next slide is cervical flexors. And the next slide we can discuss a little bit. It's movement of the cranium during protraction and retraction. So clearly we can see that the C1 and C2 are presented in red color, when the C3 to C7 are presented in this gray color. And of course, below C7 you have this light gray color, which represents the vertebra which don't move, or we are not interested in, of course, because we are discussing cranial movement. So during the protraction, when you move your head forward, just like that, what's happening is that C1 and C2 behaves differently than from C3 to C7. Clearly you can see that during extension, the C1 and C2 are going into extension, when C3 to C7 goes into flexion. And because we are flexing our neck, but the head stays in that position. So C1 and C2 must contradict the action of C3 to C7. So what's happened during the retraction? Whatever I just said and whatever you can see on the picture, just reverse it, and you have retraction. Okay, so let's go to the next slide. Craniocervical flexion and extension. So let's talk about biomechanics just a little bit. Okay, so and look at the picture as I'm telling you that, so you can clearly see what I'm seeing. Okay, so the atlanto-occipital joint during head craniocervical extension, the head rolls backwards but slide in the opposite direction. Why? Because otherwise the head would fall off our trunk. So of course that has to be rolling in one direction, but at exactly the same time head slides back into its original position. Okay, at the same time atlanto-axial joint pivots backwards, and the inner cervical vertebra slide backwards. So all together, as you can see on this picture, we can accomplish up to 80 degrees of craniocervical extension. Okay, so let's talk about picture on your right hand side, or picture B, let's call it. So during craniocervical flexion, all the movement above just simply reversed. So whatever I said and whatever you can see on the left picture during the extension, just reverse it and you got flexion. Okay, this motion you can actually flex somewhere in between 45 and 50 degrees would be considered normal. Okay, let's go to the next slide. Craniocervical rotation. Okay, we talk about rotations between skull and C1 and C1 and C2 and the rest of the vertebra already, but let's just say it one more time. The normal range of craniocervical rotation is 90 degrees. Okay, but how does this work? 90 degrees. I don't have 90 degrees. I have hardly 45 because I have neck issues as well as my lower back issues. So I'm not the best example, but I will try my best. So you should, if your neck is normal or stereotypically normal, you should be able to go all the way to 90 degrees, or in other words, the chin should cover your shoulder. So that would be considered 90 degrees to the left and 90 degrees to the right, on my right, right? So that should give you 180 degrees. I probably have only half of that, but that's what normal, again, people should have, or you can expect that from people who didn't do wrestling for many years like I did, and now I'm suffering the consequences. Okay, so again, just a reminder that at the atlanto-axial joint region occurs about 50% of the entire rotation, right? We talked about it already. So between C3 and C7, when you combine those little rotations, you got the additional 50% for a total of 100%. Okay, let's go to the next slide. Craniocervical lateral flexion. So during craniocervical lateral flexion, occipital bones rolls on the atlas. During this movement, there is some compression and distraction of the joint surfaces. So what I would like you to do is pay attention to the right side of that picture when you got those cervical vertebrae, and you can clearly see those arrows. On the left hand side you can see arrows pointing up, and on the right hand side you can see the arrows pointing down. So the spaces between the cervical vertebrae are narrowing on the right hand side when you see the arrows going down. We call this compression of the joints. So what's going to happen on the other side is going to be a decompression or distraction. Decompression or distraction of the joint. So on one side the space becomes narrower, smaller. On the other side you expanding the space. Okay? Okay, intracervical region C2 to C7, joints slide downward and inside. And again, just look at the picture. Of course, slide downwards and inside on the side of being actually flexed. On the other side, we can observe joint distraction, so it happens just the opposite. What's normal? Again, I am a lousy example, but I will do my best. So this is lateral flexion, and that's all I got. Well, it's really, really pathetic, but normally you should have 40 to 45 degrees. Women usually are a little bit more flexible than men because of the muscles. So can you imagine? Oh, this is really bad, because 45 degrees I should be here. Wow, it already hurts. So that's it. Again, let's go to the next slide. Some muscles, trunk flexors. Again, important muscles to have in mind, especially one. It's kind of my weak point. So I would like to talk about one of those muscles. You got trunk flexors. So rectus abdominis, obliquus internus abdominis, obliquus externus abdominis, and psoas, major and minor. So technically those are your trunk flexors. However, some of those muscles, if not all of them, of course, are very important when people have a lower back problems. Psoas major, similarly to another muscle in your body, doesn't like to nerve to be pinched and giving wrong signals. So those muscles, in general, muscles have tendency of shortening or contracting in a presence of pain. Psoas major happens to be one of the strongest muscles in your body. Not saying that it's the strongest, because your thumb and your ocular muscles relative to its size are perhaps stronger, but psoas major is one of those strong muscles which, if that muscle contracts, you feel it. And that happened to me when I had back problems, herniated disc, compressing on the nerves, spinal stenosis on top of that, and and top that all, some osteoarthritis. So psoas major, when the psoas major contracted on me, I was literally limping, visibly limping. I could not walk straight. Why? Because psoas major was so strong, contracted so strongly, then actually pivot my pelvis, and was nothing I could do about it. So what can you do about it? Well, either you take very strong medication, you can take a muscle relaxants, and or a very deep massage. Now, the story about the massage, first and foremost, the therapist who is doing the massage needs to know precisely how and where to find that muscle. Why? because he said deep muscle lies in your groin area. So my therapists dig her little fists into my groins that I literally had to scream, and it was so painful. And there are very few actual exercises which would allow you to passively stretch this muscle. So you can do that. You can lay down, assuming that your bed or the surface you're lying on is high enough. So you lay on the, let's say, massage table, and you lay on the edge of that mat, and you hang the entire lower extremity, the entire leg, just hang from the edge of that mat and completely relax. So that lower extremity simply hanging from the supine position from the mat, from the bed, will passively stretch those muscles, psoas majors. And then again, chemicals, tablets, which are chemically getting into the muscle and not really expanding the muscle, but relaxing the muscles. And it's not much you can do about that otherwise, because it's a deep, very strong muscle. But good massage, muscle relaxant medication, and couple of those passive stretch exercises do help. And I know this from my own experience. It did help me tremendously. So if you're dealing with patients with lower back pains, knowing those muscles becomes then very important, because pretty much you know what you're doing. Okay, let's go to the next slide. You got trunk extensors. And again, I remember mentioning this before. Erector spinae, it's an umbrella name for the long list of muscles. And I don't have to read it for you. You have right in front of you. So there is a lot of muscles. The list is long. But nevertheless, there are deep muscles. Those muscles are not movers. They are stabilizers. And erector spinae is just an umbrella name for all of them. Okay, let's go to the next slide. All right, let's talk about biomechanics again. So total thoracolumbar flexion, and you can see that we're talking about thoracolumbar because the darker vertebra, the dark gray vertebra, represent movement similarly to all other pictures. And the lighter ones are the ones which we're not going to pay attention, the one which are not the part of this particular discussion. So here is the flexion and extension of the spine, right? So the total thoracolumbar flexion should be about 85 degrees altogether, okay? But remember, it's thoracolumbar. So thoracic part is going to give you some numbers, and lumbar is going to add to those numbers for a total of 85 degrees. So where this 85 degrees is coming from? 35 degrees is coming from thoracic flexion, and 50 degrees is coming from the lumbar flexion. And if you remember correctly from the previous videos, I mentioned that thoracics do not like to flex or extend. They rather be rotating. And the vice versa comes to the lumbar. Okay? Lumbars do not like to be twisted. They do not like to turn, but they rather flex and extend. That's why you have those different numbers. Okay? So let's look at the right-hand side, and you have extension. Again, you can clearly see the darker vertebrae represent movement, the ones which we're interested in, and the lighter ones which do not move, and they should not be the part of this discussion. So total extension is between 35 and 40 degrees. But again, they're going to come from different areas, different numbers. So where we got this, let's say 45 degrees. So 25 degrees, it's coming from thoracic extension, and 15 degrees from lumbar extension, again for the same reason I just mentioned. Okay, that's good enough for this slide. Let's go to the next one. Trunk rotators, again, those are your muscles: obliquus externus abdominis, obliquus internus abdominis, latissimus dorsi, and rectus abdominis. So you can see clearly that people who are going to the gym and exercise, well, at least my experience was that a lot of those people who really don't understand human anatomy and physiology, they focus on certain muscles, forgetting or disregarding others, right? So latissimus dorsi and rectus abdominis are those muscles which people focus on because they show obliquus externus abdominis, obliquus internus abdominis, extremely important muscles, are, well, again, according to my experience, are usually forgotten. Well, why? Because they lie deeper. They are extremely important, but they do lie deeper, so they don't show. Okay, let's go to the next slide. Here we are, trunk rotation. Okay, so again we're gonna talk about trunk rotation, and you got beautiful pictures, beautiful drawings representing everything what I'm going to talk about, but let's digest that together. What are we looking at? Okay, so the starting position is standing straight with the head towards your, let's say, left shoulder. You can start from left or right, but for our argument's sake, and argument's sake only, let's start from the left hand side. So for example, you're standing in the anatomical position and turn your head all the way to the left. Should be 90 degrees, right? It should be, not in my case. But we're gonna call this point 0, or starting position. Okay, next we turn the head to the opposite direction, and then of course we are going to follow head with our trunk. Okay, so in other words is cranial thoraco lumbar rotation. Cranio-thoraco-lumbar rotation, because we're really utilizing now the entire spinal column. Every vertebra in our body we can rotate, we will do it. Okay, so in total we should achieve 125 degrees. So where this 125 degrees actually is coming from? Well, this includes 35 degrees from thoraco-lumbar rotation, thoraco-lumbar rotation, where 30 degrees come from the thoracic rotation, 5 degrees comes from the lumbar rotation. Remember I said before, lumbars do not like to be rotated, so they're gonna give you only 5 degrees. And of course, we mentioned that before, 90 degrees come from the craniocervical rotation. So you got 90 degrees, and then you got 35 degrees, 30 comes from thoracic, and only 5 from lumbar. Okay, of the total, of course, of 125 degrees. And as you can look at the picture, especially the top one, it's actually very nicely gives all the number we just discussed. Okay, so let's go to the next slide. Here we are having some more muscles, just for fun. Other trunk muscles, elevators of the pelvis, and you got a set of those. And let's talk about those muscles, what they can do. Lateral flexion of the spine, lateral flexion of the spine. So again, on the left hand side you can see how this movement occurs, what is this all about, and on the right hand side you have the biomechanics of what's going on within the vertebrae themselves. So you can clearly see that we have this compression again on one side of the flexion, then you got the decompression on the other side, the one which is actually elongating, and you got some sliding motions of the vertebra. On the side of the compression, the arrows goes down. On the side of the decompression, the arrows goes up. Okay, so let's talk about those numbers again. The normal thoracolumbar lateral flexion should be about 45 degrees. But where the 45 degrees comes from? Where 25 degrees comes from the thoracic lateral flexion, and 20 degrees comes from the lumbar lateral flexion. So again, thoracic will give you that 5 degrees more than the lumbar part. Okay, and I think we covered pretty much everything what I would like you to know from this particular slide. So let's go further. Line of gravity. Okay, so just as a therapist is very important, because the line of gravity tells you a lot about the person. It's going to tell you if the person suffers from excessive lordosis, excessive kyphosis. It's going to tell you even about the strength or tone of certain muscles, how the person can sustain his or her own weight and stand nice and straight against gravity. You can observe the head, the facial expressions, the guarding posture of the body, if there is a pain involved in this. So just by observation, just by looking at the person, you can tell a lot. So the line of gravity, if you imagine that line, will help you tremendously. And I strongly encourage you to do it in front of the mirror. So let's talk about it. In person with ideal posture, the line passes through mastoid process. Mastoid process, it's right here. So you can take the center of the ear and go a little bit lower. Right here is your mastoid process, okay? Anterior to the second sacral vertebra, posterior to the hip. It's right posterior to the hip. It's not significant. And right anterior to the knee and ankle. So again, I strongly encourage you to stand in front of the mirror and check your own posture, or your loved one, or whoever else you can put your eyes on and get them to stand for you nice and straight and kind of pose, and make sure that you understand where the line of gravity goes through the human body, because again, you as an OTA already have observational skills developed, but as a full-fledged OTR, you need this skill to be taken even to different level, because after all, you are going to be responsible for evaluations of your patients. So let's go to the next slide, and this is the sitting posture. So of course, on the left side is the bad one, and on the right hand side is the good one. So the first difference you can clearly see is the fact that on the right hand side you can see a pillow behind the lower back, where on the left hand side you do not. So lack of pillow, eventually it's going to cause you to lean forward, right? The head is relatively heavy, so what's going to happen is that in order to keep that heavy head up, you will have to go into deep extension, which we already discussed. So you know exactly what's happening, extension and flexion in cervical vertebrae. So we are forcing our muscles to work the way they really shouldn't. You can clearly see that muscles up front are shortened or contracted, and the muscles on the back are elongated, which is unnatural, and it's going to, and of course the gravity works 100% of the time. So eventually you are going to put those muscles in imbalance, and you are going to experience some pain and discomfort. So good seat it's very essential, right? So the small pillow behind your lower back, it's going to help you tremendously. And similarly, you really should have arm supports because otherwise, especially when you're sitting hours upon hours in front of the computer, what happens, and you can see that on the left hand side, that gravity constantly pulls, so the gravity pulls the elbows down, therefore it's pulling your shoulders down. Okay, so the whole posture changes. So in order to keep our shoulders nice and straight the way they were designed to be, you need an arm support. Okay, what is the appropriate arm support? Is about 1 inch above your 90 degrees. So if you put your elbow at 90 degrees, the correct arm support should lift your shoulder up to 1 inch. Not more than that, because you're gonna end up looking like this, but no less either, because otherwise you're simply not doing any good for the shoulder. You're not relaxing those muscles, and you're not relaxing. It's not only muscles, but think about the capsule itself, right? The shoulder capsule itself. You're pulling down, so you're pulling not only on muscles, but on everything else. You're pulling on ligaments. You're pulling on the capsule itself. You're pulling on the tendons. So it's really a lot of structures which are involved. Having said that, let's go to the next slide. Well, we're gonna talk about some problems. As you probably realize, whenever we have something good, something bad is happening, right? So we have problems. So we're gonna talk about osteophyte formation, spina bifida, kyphosis, lordosis, scoliosis, spondylolisthesis, and herniated discs. So let's go to the next slide and let's start talking about osteophyte formation. Osteophyte formation is when, and you can clearly see between the C2 and C3 vertebra, you have this whitish substance which is intervertebral disc. Now those intervertebral discs with time get damaged for a variety of reasons. That could be dehydration, that could be arthritis, that could be mechanical injuries, could be many things, but nevertheless they are thinning out. And between C3 and C4 you can see the degenerated very thin layer of that disc. So what's going to happen? The vertebra start to touch the other vertebra, right? The vertebra below it. What's going to happen is, imagine going to the gym and lifting weights and not using any gloves, any protections for your hand. What's going to happen? You're gonna develop calluses, probably in those areas, right? Probably in those areas. Boxers and other sports who use their hands to hit, for example, heavy bags, have calluses right here on the knuckles, right? So this is a very similar concept. Bone rubs on bone and the callus develops. But this time is a little bit more complicated because the callus is an actual bone, right? And of course this is not good because this bone is going to compress on the nerves and cause a lot of pain and discomfort, and sometimes immobilizes people. So range of motion, strength is going to be involved in that as well. And on those x-rays, actual x-rays, you can see on the top picture where it says anterior view, this is actual a picture of a model, and those nerves are just drawn on that model. But the lower picture is actual x-ray of the knees, and you can appreciate those osteophytes over there. Those lines, those arrows are showing you exactly where those osteophytes formated. All right, let's go to the next slide. Kyphosis. Okay, we talked about kyphosis normal kyphosis and normal, for example, lordosis. I'm sorry, I lost the word for a second. So kyphosis and lordosis, they are normal. We all appreciate that, because otherwise, if our column would be completely straight, then the weight which we have in front of our bodies would be too much to handle by our vertebral column. So the normal it's okay, but what's going to happen when this goes out of whack and becomes abnormal? So the top left picture shows you normal spine with this normal kyphosis and lordosis, and on the right side of the same picture you got kyphotic spine. It looks really bad on this drawing, but I assure you that in the real people it looks exactly the same. So let's look at the picture in the middle of your screen, and one of those pictures on the left is MRI, when on the right is an X-ray. So on the left, the picture B has a big B on the bottom of the picture. It shows you, this is an MRI, shows you the vertebra and how the vertebra are squeezing the actual spine. You can only imagine how painful and sometimes debilitating this can be. So this person went for surgery, that no therapy can fix that. So on the right hand side, the picture C, you can see that post-surgical picture. This time this is an X-ray, and you can clearly differentiate MRI from X-ray, because MRI shows you actual soft tissue, so it's very detailed, when the X-ray shows you only bones. So you can see that this person had, of course, the external device installed, and eventually this device is going to be removed, but the time of healing is long, right? Takes months. Okay, and on the right hand side again you got normal and excessive kyphosis and excessive lordosis. And this happens in real life. You can see the picture of real people on the bottom of the screen, to the left and to the right. You can see the person on the left, the lady on the left, has kyphosis and lordosis. You can observe this kyphosis in her on the upper back, and the excessive lordosis in the pelvis area. And the same thing actually happens in this gentleman on the right, excessive kyphosis and excessive lordosis as well. All right, let's go to the next picture, or the next slide. Okay, so lordosis, you can, same story over here. You can see the X-ray in the middle of the slide. Again, this is a cervical lordosis. Lordosis in cervical area, it's normal, but clearly this is excessive lordosis. You do not want your neck to look like this. And you got lumbar lordosis on the right, when the gentleman is standing with the protruding hips, and his stomach protrudes forward, and you can observe his back. So he got some kyphosis in his upper back and excessive lordosis in his lower back. Okay, let's go to the next slide. Spina bifida. Well, spina bifida, people are born with spinal bifida. Those are just some pictures. You can even see the cat born with spinal bifida. So sometimes the spinal bifida is not as extensive, and sometimes it is. And of course, all depending of the severity of the protrusion of the actual spinal cord through the skin, and how much of the spinal cord was affected and how badly. So you can appreciate it by looking at the right lower corner. You have a drawing of the nerves coming out of the canal it normally should go, but perhaps the bones didn't fuse or didn't fuse correctly. There was an opening and the nerves are coming out as opposed to be held within this, the column. And people suffer sometimes very badly, of course, depending of severity. Sometimes people, they are wheelchair bound for the rest of their lives. And I did have a couple of patients who were unfortunately bound to the wheelchairs for the rest of their life. What can we do about it? A lot. We can teach them how to be independent regardless of being in the wheelchair. Okay, so let's go to the next slide. Those are different type of postures. On the right hand, right hand side, you can see the good posture, and to the left, of course, all of those problems: forward head, thoracic kyphosis, lumbar lordosis, and sway back. Those are all conditions which of course you have to pay attention to, because only when you have a good posture, all the muscles and internal organs even will work correctly. Remember that this is not only the muscle imbalance, but we're creating tremendous forces on the joints. So the bad posture will cause not only the weakness of the muscles, which are unnaturally elongated, but also we elongating parts of the joints, we compressing other parts of the joints, and eventually a small problem can become big one. Okay, let's go to the next slide. Scoliosis. So this is a deformity of the vertebral column, of course, and we all probably know somebody with scoliosis. It's very common. It's characterized by curvature in all three planes, so it's not necessarily going from left to right or right to left, but in addition, forward and backwards. Okay, we have two types of scoliosis. One is called functional, which can be corrected by shifting to the right posture, by right exercising. The functional one could be due to, for example, occupation. And why I'm saying this is because I had a patient that was a severe case when the lady was, her job was to loading and unloading UPS packages from the trucks. She was doing this day in and day out, hour after hour, 5, maybe 6 times a week. Clearly, nobody paid attention to biomechanics, because when I asked, she said that with that heavy load, she was turning and placing those packages down. And of course, to save time and meet the quota, there was no time to shift legs. So she was simply twisting her body with the heavy loads. She was young at the time, that was many years ago, but at the time she was fairly young. She was perhaps late 20s, maybe early 30s, and her entire body was laterally flexed to the position I'm showing you, perhaps even more. She was incapable of walking straight or righting her body. Of course, she went to the doctors for second and third opinion. Everybody refused the surgery. Why? Because this was not a mechanical injury. This was a learned functional behavior. She started to develop problems in her vertebral column. She started to develop herniated discs because of her job. So what's happened is that we naturally don't like pain. We just don't. Body behaves the way that if you do feel pain, you start to move, walk perhaps, the way to get a least pain possible. Like in my example, when I had a very bad back pain, I started to limp. I didn't limp because something was wrong with my legs. I started to limp because muscles contracted my pelvis went out of whack, out of alignment, and I found out that by limping I hurt slightly less. So trust me, brain is smart. Brain is going to whatever it takes to lessen the pain, to lessen the discomfort. So she, coming back to my patient, she started to feel a little bit better when she twisted to the side, when she flexed to one side. Then that wasn't enough. She flexed a little bit more. Then that wasn't enough. She flexed a little bit more. Ended up walking like this 100% of the time. So when she finally went on disability or temporal disability, I don't really know exactly, she went to the surgeon and asked for opinion. None of the surgeons she went to, and if I remember correctly, she went to like 3 of them, told her that he's going to perform surgery on her because it's a learned behavior. So as soon as the surgery is done, she is going to go into that position because she learned that position. So it's not really structural, is behavioral, is functional. So they told her that she needs therapy before actual surgery can happen, or they can perform the surgery on her, because she would destroy whatever they did very fast, and then she would need another surgery, even if assuming that it would be possible. So she needed to retrain her brain, start to walk straight regardless of the pain, and only then the surgery could be done. So that was really severe case of scoliosis. Well, not scoliosis really, although yes, she developed scoliosis because of her bad posture. Okay, so the second type of scoliosis is structural. People are born with structural changes, and this is a little bit grimmer case scenario for us therapists, because in vast majority of times we can't really fix it. We can help by providing education, biomechanical education, biomechanical training, how to lift objects, how to move, etc., but we can't really fix the problem because someone was already born with that. Okay, those inborn pathologies, 80 to 90% of the time we are considered idiopathic. What that means? Well, that means that we don't know why, and women or girls at that time, or baby girls, are actually born with this condition, percentage-wise, much higher percentage than the boy babies. All right. So you can see those pictures, those drawings with different types of scoliosis. So you can read this for yourself. We don't have to go necessarily together through that. Let's go to the next slide. And my throat is already giving me some troubles here. I talk too much. Okay, so those are pictures of the real people suffering from scoliosis, and X-ray of scoliosis as well. So you can see pre-surgery picture and post-surgery picture. So with the pre-surgery, you can clearly see that no therapy can fix that, and after surgery, we probably would see that patient to to help them recuperate, recover, and get those daily activities in as good biomechanics as possible. Okay, let's go to the next slide. Spondylolisthesis, it's a dislocation of one or more of the vertebrae. So here you can see very clearly that had to be mechanical. I personally don't think that people are born like this. I think this is due mostly to mechanical injuries, either sport-related injuries or even more so car accidents, motorcycle accidents. And you can see all of those pictures are x-rays, and on the left hand side they put some color for clarity, so you can clearly see that this person have tremendous problems with the lumbar part of the back. I would be surprised if this person can even walk, and that's clearly and in the middle picture you can see how much force it's required to displace one vertebra, like you can see on this x-ray. To me this is clearly a picture of somebody who went through some car or motorcycle accident, some very impactful effect to be able to dislocate bone, deep bone like that. Okay, let's go to the next slide. Disc herniations. Okay, so we got a different. You probably heard about disc bulgings and disc herniations. So we have really four. Technically speaking, there is no disc bulging. Disc bulging, we do refer, and even medical doctors refer this to as bulging, because it's the lesser degree than true herniation. So let's go and talk about those four stages one at a time. So it's protrusion, prolapse, extrusion, and sequestration. So protrusion is where even surgeons call it bulging. So this is the case scenario when therapy really works. You do not need surgery for that. A lot of people decide to go for surgery, but 90% of those surgeries are really not needed, right? So what's happening here, we can clearly see annular fibrosis is just slightly pushed out by nucleus pulposus. Nucleus pulposus, as you remember, is this kind of pudding or jelly-like substance, and when you compress enough, it starts to push to the outer walls, annular fibrosis. And annular fibrosis, of course, creates that slight bulging. If the person is really unlucky, that bulging will be created at the precise point when it actually compresses on the nerve. And even a slight bulging sometimes can be very, very painful. However, this condition can heal. The person can heal with appropriate change of behavior, appropriate exercises, strengthening muscles, of course, around the area, medication such as muscle relaxants, and protrusion 90% or more of the time does not require surgery. Prolapse. Well, prolapse is a little bit different. Now, this picture is a little bit misleading because prolapse, its nucleus pulposus reaches the edge of the annular fibrosis to the outside, but is still confined within the outer layers of the annular fibrosis. So it doesn't really go too much out yet. Now, what does this mean? That means that this condition can be significantly more painful than protrusion because now that bulging is more prominent and chances of hitting the nerve are much, much greater. Can therapy help in this case? Absolutely, absolutely. Again, most people in that stage should not go for surgery as their first choice. They really should go for therapy, change the lifestyle, perhaps change even occupation if they can, and in most cases the surgery would not be needed. The next one is extrusion, where annular fibrosus actually ruptures, so nucleus pulposus escapes into the epidural space. Now, can therapy help? Yes, it can, but at this stage probably surgery would be recommended, because now you have the nucleus pulposus actually outside the disc itself. Chances of complete recovery and not going through surgery are slim. So this is when a majority of people decide to go for surgery, and I can't blame them. Why? Because this is the stage where I found myself, and honestly, I lived with this condition. I pushed myself through this condition for 10 years. After 10 years, I didn't get any better. The things only got progressively worse. And finally, I said to myself, I'm done. I can't live like this anymore. I knew the risk of surgeries. You ask people and they scare you. They tell you, oh, they can slip something and they're gonna make you disabled for the rest of your life. There are great chances that you're gonna end up on the wheelchair for the rest of your life. But once the pain gets so bad and influences every aspect of your life, I had so enough that I said, okay, you know what, I am going to take my chances, because I can't live like that any longer. And thankfully I can walk. I got significantly better after the surgery, so the surgery worked. Now, work 100% of the time? No. I would say 80%, 75 to 80%, but it allows me to live fairly normal life. That's one of the reasons why I'm not active occupational therapist in the hospital setting anymore, because I physically can't lift people or help them transfer or help them the way they should be helped. And second reason, of course, because I love teaching. I really do like teaching. I love academia. So there is, of course, a few reasons why I teach, but one of it, or the first idea of transition from clinical side to academia was caused by my condition. Sequestration is the worst case scenario, is where the parts of the nucleus pulposus itself lodges within the epidural space. So this case scenario will require surgery, no question about it. Okay, let's go to the next slide, and you can see the disc herniations. You have MRI on the left hand side, picture of an MRI, and of course very nice drawing to your right. And on the MRI you can clearly see the herniated disc compresses on the spinal cord itself. This can be actually very, very dangerous, because if the herniation progresses, then of course this can immobilize the person, can paralyze the person, and this you can see this is actually a very, very bad case scenario. So this person had to go through surgery. And this is the last slide for this presentation. So I thank you very much for attending, listening to me, and I see you next time. Bye now.